Okay, so hello everybody, good afternoon, and I'm very pleased to be here today with you to speak about personalization of radiotherapy treatments. So I'm Charlotte Robert, I'm Associate Professor in Medical Physics at University Paris-Saclay, and I'm working as well as researcher in the radiotherapy department at Gustave Roussy Institute. I don't know if you are all aware of what is Gustave Roussy Institute. So it's a cancer center. So we are doing just oncology. And it's quite a big cancer center because it's the big cancer center in Europe. And our group are mainly working on the optimization of radiotherapy treatments. So my conflict of interest is the following. So we have currently access to the Circular Perfusion software solution on loan. And as it was said by the others, so I'm a physicist and not physician. So I will speak more on the AI topic than on the perfusion topic. But you will see how we can we can use the perfusion information in order to improve our AI models. So all the things I will tell you today as part of a big project that is called AI Dream Project. This project is funded by the French government, so BPI France, it's in French Banque Publique d'Investissement. And AI Dream means Artificial Intelligence for Diagnosis, Review and Radiomics Acceleration in Medicine. And this project is led by GE Healthcare. It's a big overview in this slide of what the AI Dream project is. The objective of AI Dream is to create a platform to accelerate and reduce the cost of developing AI application for imaging. The goal is to industrialize production methods. So you have here it's the connection. So here you can see it's just to explain to you what is our goal. So here you have the example of, for example, a phone. And the goal is to really facilitate the use of AI solution by just plugging this AI algorithm into this, here in this case it's the phone, but in our case it's a platform that can aggregate all this AI solution. And in this project, Gustave Roussy and other hospitals, so you can see, for example, La Pitié-Salpêtrière as well in Paris, we are involved in one work package that is dedicated to therapy. And our goal is to show that using AI, we will be able to optimize, improve the survival of glioblastoma patients by changing the way we are delivering the radiotherapy. So it's our work case. And I will just make some reminders for you regarding gliomas. And I'm thinking that you are perhaps better expert than me. But it's just some small reminder from the radiotherapy point of view. And so you know that the classification of the gliomas has changed in 2021. And now in the category of the grade 4 gliomas, we are including GBM wild type plus astrocytomas IDH mutant. And regarding the figures, so GBM IDH wild type, you know, I think, then the survival is very poor and that less than 5% of the patient will survive more than 5 years. And another point that is of interest for us in radiotherapy is that for these patients, the tumors, they are really radio-resistant, and that the recurrence, they are mainly observed in the irradiation field. That means that with our radiotherapy treatment for the moment, we are not able to correctly sterilize stop the proliferation of the cells in the irradiation field. And you have some interesting figures that have been published in the Journal of Neurosurgery in 2021, showing that depending on the extent of the surgery, the recurrence patterns are different. And if you have a subtotal resection, you can see that majority of the cases, they are recurring locally. And on the contrary, if you are able to correctly remove the majority of the lesion, you see that the patterns are quite different, and you see that the local recurrence is decreased, and you see an augmentation, on the contrary, of the distance recurrence, showing that, and it's true as well for the survivals, that we need to remove the majority of the lesion in order to improve the survival of the patient, but as well to decrease the risk of local recurrence. And so I think that you are aware as well of this. This is the conventional treatment for glioblastoma patient. The conventional treatment is the STUP protocol. And in this protocol, you have first the surgery, next the radiotherapy that is combined with a chemotherapy, it's temozolomide, and left you have an adjuvant chemotherapy. And our goal in this quite big project, the AI Dream project, our goal is really to use these MRI images that are acquired post-surgery but before the radiotherapy in order to understand where the lesion is the most aggressive in order to change the way we are treating the patient. And for that, we have been able to compile and structure and annotate a quite big database. So we have a 1,000 patients database that integrates clinical plus imaging data. For the imaging data, we have been able to retrieve the post-op pre-RT MRIs plus the MRIs at the time of relapse. And our goal is to develop AI tools to identify the aggressive part of the tumor and the part that will relapse at the end in order to change the way we are treating the patient. And well, I think you are not radiotherapy experts, and just a small overview of what we are doing today and what we want to do tomorrow. So here you have a quite standard conventional delineations of the volume of the radiotherapy. So in this case is T1 enhanced MRI, and you see that the volume that is defined as in our vocabulary is the gross tumor volume. So if the macroscopic disease here is in red, so it's the enhanced signal. And you can see that we extend this signal. We are applying 15 millimeter to 20 millimeter margins in order to include as well the microscopic disease. And you see that today, for all the patients, we are giving the same dose to the whole tumor. So it's 60 grays that is delivered to this very big blue volume. And it's the same for all the patients, and we are not, for the moment, we are not describing the aggressiveness of subregions of the tumor. And our goal inside of this project is really to change that and to go to what we call dose painting. So the goal is to identify pre-radiotherapy, but post-surgery, the most aggressive parts of the tumor in order to give more doses in that regions. And our hope, our dream is that this will increase the survival of the patient. So where we are in this project, so the database is created, is annotated, and I will explain to you what we call by annotations. And we are at this stage in which we want to develop AI models in order to predict find a way to predict where the tumor will recur in order really to change the treatment. So here are the numbers of, it's a description of our cohort. So in our cohort, we have 974 patients. You have here all the descriptions. The only bad point in our cohort is that we were not able to retrieve all the MGMT status plus the IDH status. You can see for the IDH, we have about just 900 patients for whom we have the ADH status. So we have some data missing regarding the molecular mutations. And I said before that we had annotated all the cohorts. How we have done that? We have developed an automatic contouring tool based on the BRATS data. I don't know if you are aware of this kind of challenge. So it's a challenge that is yearly proposed, and the challenge gives you some annotated images, and the goal is to obtain the better tool to make some auto-segmentation. So we have participated during 2 years to this challenge, and we have now a tool that is able to not just contour all the lesions, but contour subregions of the lesions. So we have the necrotic part, the enhancing part, the edema, and now we are working on the development of new automatic labels that correspond to the cavity, because we are post-surgery, and as well post-operative modifications. So we have now a tool that is capable of correctly annotating all these subregions, and we have managed to integrate our tools in the platform that is developed by General Electric. And like this, we have been able to annotate 2,000 images. So we have 1,000 patients, but 2 times. So we are in the process of finishing the annotation of all these images. And as I said before, our goal is to predict the sites of relapse. So our first attempt was to use just the conventional anatomical MRI, so the T1 with gadolinium, and the T2 flare. So here it's where we were some years ago. So we have annotated for 200 patients, so it was some years ago, the pre-RT time images plus the relapse time images. And our goal was to see if by deep learning, so it's an AI model, we have used UNet for the one, it's a really conventional deep learning algorithm. And we have tried to see if just by using these maps, so you give to the tool the pre-RT anatomical MRI, and the goal is to, for the network, is to detect features that would be able to predict the relapse maps. What I call relapse is the new contrast enhanced signal. And to be honest, at that time, some years ago, our results were very poor. So in that case, it was just anatomical images. And here you have the results. Here are the DICE results. So it's a performance index results regarding segmentation task, showing the goal is to have one value at the end. And in that case, we were able to obtain just 0.2 values. So to be honest, it's really poor. So what does it mean? It means that based only on an anatomical conventional MRI, we are not able to find in the images, in the pre-RT images, the signal that is able to predict the recurrence. And that's why we have changed our strategy last year, and we have discussed with the CERCER team in order to have access to these new maps proposed by CERCER, in order to use their maps as new channels, so new inputs of our deep learning model, to see we can improve the performance of the prediction of the relapse site. And this was done last year, and we are continuing on this path. And I have just here tried to summarize what is the state of the art regarding the use of this advanced perfusion image preprocessing methods applied to gliomas. And you can see that perhaps my literature review is not completely full, but you can see here that for the moment what is published is mainly on the distinction between high and low-grade glioma, on the distinction between pseudo-progression and progression, the prediction of the survival, and for the moment we have nothing on the prediction of the relapse sites at the voxel scale, because here I really speak on the voxel scale. And just to show you how these maps can be of interest for you, I have selected 2 clinical cases. It's good cases, but to be honest, on the we have 200 patients that have benefited from this DSC sequences, so we will not be able to make the analysis on the 1,000 patients, but just on 240-something patients. And here you have just 2 cases, but they are really illustrating what we have seen on a high number of patients. So in that case, it's a 57-year-old man with a KPS of 60. You can see you have here all the history of the disease. So this man was diagnosed with the disease in August 29. And this person, he has 2 lesions and only one. So it was the right temporal insular lesion that was biopsied. And it's a GBM IGH wild type. And what you can see here are the pre-RT images. So you can see here an hyper signal on the T1 injected. The flare signal is quite mixed. And you have here at the biomarker maps acquired pre-radiotherapy. Okay? So it's at the same time as this T1 with gadolinium and T2 flare acquisition. And what you can see is that in that case, all the signals, they are quite in concordance. So you have a quite high signal in the RCBV maps, the same for the CTH. And you can see here it's the, sorry, it's in French. Here you have the image at the relapse time, and you can see that the tumor is still active. So relapse is really after all the Stupp protocols, so it's really after the radiotherapy. So this was for the biopsied lesion, and we have the same images in that case for the non-biopsied lesions. So you can see in that case, the image is still pre-radiotherapy. So here you have an active lesions with ring-shaped and signal. You can see here an increased signal as well in the flare images. And in that case, you can see we have quite divergence between the RCBV signal that is quite low and the CTH that is high in that case. And in that case, the relapse seems to say that the CTH was right and the recurrence was expanding from that site. And another very interesting case, and this is one of the most optimistic case to validate the performance of the circular maps. So in that case, it's a woman that is 64 years old with a very high KPS as well. And in that case, sorry, so you have here the images as well before the radiotherapy treatment. So a very high signal on the T1 with gadolinium. In that case, the flare was quite mixed. So you have here in that red circle a not so high intense signal on the flare. Here you have a very high signal on the flare image. Perhaps here is a strokes. And here you have the maps, the perfusion maps that were acquired still at the time of the before the radiotherapy. And what is interesting in that case is that the RCBV, the values there are very high. The CTH has quite no hyper signal. And here you have the value of the RCMRO2. And what is interesting is that at the relapse time, you can see that there is no activity at all in that part. And the recurrence was near the ventricles here, where the CTH has a high signal, showing that it seems that the CTH is very informative for our task, that is really to identify the most aggressive parts of the tumor. And to verify that, because we have open, I think, 30, 40 cases, but it's quite difficult to compare all the signals and draw some conclusions. So in order to go to more quantitative values, we have moved to a cohort study. And so for the moment, we have been able only to analyze a sub-cohort of our big cohort. So we have just 104 patients that were diagnosed with IDH mutant astrocytoma or a glioblastoma IDH wild type. And what we have done is that we have rigidly registered the pre-RT images, including anatomical images plus the DAC sequences that allows us to obtain the biomarker maps, the perfusion biomarker maps. And we have registered all these images to the relapse. And as I mentioned before, we have annotated by subregions all our images, so before and at relapse. And like this, we have been able to create two outputs that we want to predict, is the enhanced signal at the relapse time and the enhanced signal at the relapse time, to which we are subtracting the L3, so it was the enhanced signal before radiotherapy and the necrotic region before radiotherapy. So what does it mean in that case? The goal is to see if in our biomarker maps we are able to predict relapse in regions that were healthy before radiotherapy. But in that case, the goal is, the task is really hard. It's to see before the radiotherapy where some voxels will relapse, even if they seem to be healthy pre-radiotherapy. So it's a quite complex task. And we have proceeding like that. So we have the biomarker maps, and for all the pre-RT biomarker maps, we have changed the threshold, and we have seen the ability of these maps to predict the recurrence depending on the threshold. So like this, we are able to create some rock curves. And here are the preliminary results that we obtained. So for the moment, our conclusions are that the CTH have the higher predictive value compared to the other biomarkers. And you can see here that our results are quite good. You know that at the end, the goal is to put all these maps as inputs of a deep learning software. But for the moment, our goal is really to see if we have signal in our maps, map by map. And you see that just regarding the CTH, we have really signal because we are able, when the CTH is high, it means that in a lot of cases, voxels will relapse at the end. And you see that it's the same predictive value when we just want to see if some healthy voxel will become recurrent at the end, and we have quite very good results. For the moment, we have find the threshold, but we need to confirm that on the test set, so on an external cohort. And you can see that really this CTH outperform conventional CBV maps, because for the CBV you see that it's really random. So the signal on the CBV is really not specific enough to be able to predict something at the end. So just to say that before us, another team in Toulouse in France has already analyzed the capability of perfusion maps to predict the relapse sites in glioblastoma. And you can see on that figure, and I can give you, if you are interested, the paper. But it shows that really CBV alone is not predictive at all of the relapse site, and it was the same for the diffusion. Here are my conclusion and perspective. So you see that for the moment we have been able to establish a very large-scale retrospective multicentric cohort that include today about 1,000 patients. We have been able to retrieve the pre-RT post-operative perfusion images for the moment 241 patients. And the final analysis is in progress to be able to compute this specificity, sensitivity performance here at the voxel scale. And we are in the process with La Pitié-Salpêtrière of creating an independent test cohort in order to validate really see if we are able to obtain the same conclusion on the cohort and to validate at the end threshold and the predictive performance of the microvasculature biomarkers. And as I mentioned it before, because it was really our main goal, the goal next will be to integrate all these new biomarker maps as additional channels, so really put these maps as inputs of a neural network in order to see is by putting these new maps, we are now able really to predict at the voxel scale the sites of relapse. So thank you for your attention.
Thank you for a very interesting and very impressive talk. Are there questions from the audience?
In the second phase, the CTH was read all over the necrotic area. What seemed to be no, the case before. Yeah. So, what should be the meaning of? I mean, the CTH being in the necrotic area? Is it an artifact that we have sometimes? The CBV is very red in the cells. I mean, just on liquid, or is it really meaning?
Yeah. I agree, and we have this discussion during the lunch. We have to observe at the LY maps as well in order perhaps to remove some signal that is not meaningful enough. So yeah, it was the discussion. So we have to use additional maps to give confidence. That's right in our... Because for the moment, at that time, it was just observation with the goal to put that in a deep learning network at the end. But that's true that we have perhaps to remove signal before putting the maps in the network, right?
I had a question. I think earlier we talked about leakage correction also for these maps. Is there a kind of leakage correction in place in this one? You know?
Yeah, to be honest, I'm not really an expert in perfusion, so we have to really see with Aurelia, and she will come next week to check that our settings are the optimal one in order to create the maps. Yeah.
Thank you very much. So are you planning to use these data to give an additional boost on that particular area? Is that sufficient? I mean, with an AUC of 0.7, are you?
No, the goal is, that's why our goal here was just to see if we have signal, predictive signal, because, you know, by just opening images for the CBV, visually we find no signal. So here now we are sure that we have a better signal that's just in CBV, for example. So the goal is really to put that as input of a deep learning. So use the T1 with gadolinium, T2 flare, CBV perhaps, I don't know if it's meaningful, but CTH and all the maps as inputs of the neural network in order really to combine the information of all these maps, not just use CTH to make the boost.
So what is your criteria? I mean, how good does it have to be before you add additional radiation to the patient's brain? And also remembering that 60 gray is like, you know, you're at the max in terms of tox. You can only go to 90 gray, but then you have a lot of toxicity And even with the boost, I know maybe you give 12 or something. But,
Yeah,
but
in the...
I'm just
No, but
testing your level of confidence in the images in order to take a treatment decision on the patient.
I agree, and you have to know as well that we have a group of Toulouse have obtained the results. I don't know if you are aware of the SpectroGlio trial that boosts on spectroscopy information, and they give 12 grays boost to these abnormalities, and the results are negative at the end. So, yeah, I agree.
There's a question there.
But there are some results from UPenn that seems to be they have managed to train a deep learning network, and they are boosting it. Apparently, the paper is not here for the moment, but they have presented very good results recently. So, fingers crossed.
Congratulations for the nice talk. Can we go back to the patient number 3?
There are only 2.
Oh yeah, only 2. So could you explain why this CTH values are different in 2 different areas? In one area we can see that CTH is increased, the enhancing part, and the other part which shows recurrence later on the CTH is a bit different. So it's like kind of a contradictory to itself. So what is the CTH? Increased CTH suggest necrosis or the recurrence. So how can we interpret the CTH results?
To be honest, I'm not enough expert in that interpretation, so I will not be able to answer to you, but I would be very happy to discuss with experts in order to really make the most of our maps.
Maybe I can add that at least in some of the publications I've seen it sort of people hypothesize about abnormal angiogenesis or recurrent abnormal microresonance.
But that's true that our maps, I think that for the moment they are not perfect, because you see there are a lot of signals in the ventricles, so we have perhaps better settings to put in place to improve our maps.